Good morning. I'm Dr. Tom Masterson from the University of Miami Desai Seti Urology Institute.
I'm Nannan Thirumavalavan. I'm a urologist at Case Western University Hospitals in Cleveland.
And today we are going to discuss the New England Journal of Medicine's Traverse trial that was published this past year. So Nannan, this trial was looking at testosterone replacement and cardiovascular events. Why did they even do this study?
That's a great question, Tom. Thank you. So there has been some sort of debate as to the cardiovascular risk in patients taking testosterone therapy. There's a few studies earlier in the 2000s and sort of early 20-teens that showed potentially an increased risk in cardiovascular disease in men taking testosterone therapy. So in 2015, the FDA actually came out with a black box warning about testosterone and cardiovascular disease, but it's still heavily debated, which was a reason that the authors undertook this study.
Awesome. So what did they do to answer this? I'm looking through it. It's had over 6,000 patients initially enrolled in the trial. What did they do to actually determine if there's an increased risk of cardiovascular events?
So they took men who are already at high risk for cardiovascular disease and randomized them to one of two arms, either getting testosterone therapy or placebo gel, and the testosterone therapy was in gel format. And they looked at specifically cardiovascular outcomes in these men.
And what do they define as high risk? Is this somebody who's had a heart attack before? What was the patient population?
Cardiovascular risk, or sort of being high risk, was defined as having 3 or more of the following risk factors: hypertension, dyslipidemia, smoking, stage 3 CKD, diabetes, an elevated CRP, age 65 or older, having a calcium score that was above the 75th percentile for age and race.
So that's pretty interesting. I mean, that's most patients we see in that age group. Someone over 65, high blood pressure, high cholesterol, diabetes. So it sounds like they actually included patients that we would see in the clinic.
Absolutely.
So what did they do? What testosterone formulations did they use in this trial?
Yep, so it was a testosterone gel or a placebo gel, and they sort of randomized you to either group, and they dose adjusted to get you into a therapeutic range. The placebo patients also got dose adjustments, so they couldn't tell whether they were getting placebo or not.
Gotcha. So they didn't just send the placebo people off and then pay more attention to those on testosterone therapy. It's very clever.
So Tom, what were their primary outcomes that they were looking at, and what did they find?
Yeah, so they were looking at basically cardiovascular events. This included heart attack, stroke, thromboembolic events, and all-cause mortality. So interestingly, between these two groups, they actually didn't see a difference between placebo or treatment group. In fact, they saw so few events, they had to expand their enrollment criteria midway through the trial in an effort to increase these primary events.
And it's interesting, like with all trials, and I think we all know that the devil's in the details, right? And I think they had noticed something like a 60% discontinuation rate of testosterone. Is that correct?
Yeah, that was interesting, and I wasn't quite sure how to interpret that in their analysis, but they had almost 60% of the people, both on placebo and testosterone, actually discontinued during the study period. In addition to that, they had 20% of patients not make it to their final follow-up appointment. So they only had an 80%, or I should say only 80% of patients were in final analysis.
Mm-hmm. And so what do they end up sort of finding, and do you think, more importantly, are those findings valid?
So the things that did stick out was there was an increased risk of pulmonary embolism in the testosterone treatment group, as well as arrhythmias. And it's hard to know if that was due to testosterone therapy or not. It probably does require some follow-up. However, one big standout in this study is that the therapeutic range that they were targeting was that 350 to 750. But most patients were still around that 350 range. The average increase in testosterone was only about 150. So it doesn't seem like they hit the therapeutic range that they intended to. I know in practice, I personally aim for higher testosterone levels. Maybe that would change the outcomes. I'm not sure.
Yeah, you bring up a great point. I do think that some of this probably mirrors what we see in clinical practice with compliance as well. People not sort of taking the gels as often or as religiously as they need to be taking to be in that therapeutic level. So maybe in some ways this mirrors sort of real life. Yeah. One of the things that you had mentioned that I find really interesting is that sort of slightly increased risk of DVTs. never really made sense to me, because if you put someone on androgen deprivation therapy, we know that increases your risk of DVTs and PE as well. So it just never mentally made sense to me.
Yeah, it's a great question. I mean, we have this friendly sort of debate. Is there a difference between putting somebody with normal testosterone on testosterone versus somebody who already has low testosterone? Is it possible that that low testosterone state puts them at a higher increased risk of pulmonary embolus to begin with? Certainly more research is needed.
Absolutely. So would you say this paper will sort of change your clinical practice and the way you counsel men about testosterone and cardiovascular risk, specifically in a group that is high risk for cardiovascular disease?
I think it supports what I've already been doing in practice. I will tell patients that there is this theoretical risk. Now there is at least a paper to say, hey, you're probably not going to be at an increased risk of cardiovascular events. And now there's data to back that statement up.
Yeah, I would agree with that. I think that now this is a very well-designed study, and it's prospective, it's sort of double-blinded, randomized, placebo-controlled. So I think the fact that they did not find sort of a large difference or any difference in cardiovascular outcomes is reassuring to, I think, what most of us probably thought was true.
Absolutely. Thank you guys for tuning in and listening to us talk about this trial. If you have any other questions or want to see more content, please tune in to the SMSNA YouTube page.